All right, welcome. Thank you everyone for joining. My name is Brianna Banashevsky and I'm an MS2 at Mount Sinai in New York City. And we want to take this moment to welcome everyone to our annual Stand Safe event of 2021. I will be running this event along with my co-lead, Courtney, which she'll introduce herself now.
Hi, everyone. Welcome. My name is Courtney Wong. I'm a fourth year medical student at McGovern Medical School at UT Houston. Thanks so much for being with us. And this is our agenda for this evening. So we'll do a brief introduction on SAFE, and then we have wonderful panelists who will each go through their presentations, followed by Q&A, and then we'll have an open Q&A at the end.
Hello, everyone. So my name is Dennis Chital-Tepe. I'm one of the national leads for SAFE. And I just wanted to start off by thanking everyone who has helped set up this amazing event. We do this every year at this point, and it is always so exciting to be able to see how many people want to be involved and learn more about the issues that we'll be talking about tonight. So SAFE is an organization of US med students, physicians, nurses, and healthcare professionals who are dedicated to eliminating the American firearm violence epidemic through research, education, and evidence-based policy.
And I'm Selena Dubin. I'm another national lead for SAFE. We're recognizing the need to frame the firearm violence epidemic as a public health crisis, one that is both preventable and urgent. Today, SAFE aims to advance research in gun violence prevention, educate healthcare providers and medical students about the latest research in gun violence prevention, when and how to discuss firearms with patients, and support evidence-based policies to reduce firearm injury and death.
And as an organization, we have advocated for federal funding for gun violence research, along with Representative Jackie Spear and Representative Gabby Giffords. We've also worked with California Assemblyman Mark Bermanen to develop an education and training program on the prevention of firearm-related injury and death. We also hold Stand Safe, our national event, every year to unite our 50 chapters of SAFE around the US on this common cause.
And today we have the true privilege of learning about and engaging in a discussion on interventions that work for anti-gun violence. Our speakers today are renowned experts in these fields, and they have dedicated their lives to studying firearm violence and prevention strategies to protect our patients and ourselves.
So as Courtney mentioned on the agenda, our event tonight is going to run an hour and a half. And each of these speakers will present for about 10 minutes. And after their presentation, we'll have a dedicated 3-minute Q&A session where we'll gather questions from the audience and ask the speaker. At the end, after all the presentations, we'll have an open Q&A that we can ask any panelist a question. Everyone should see a Q&A box at the bottom of their Zoom screen. And so feel free to type in questions throughout the event, and you can include which panelist you want to direct that question to within the question, or leave it open to all panelists. We'll be monitoring the Q&A box throughout the evening. Before we dive into our first presentation, we're going to ask each of the panelists to provide a quick 30-second introduction. Dr. Betz, would you like to kick it off?
Sure, thank you so much for having me. My name is Emmy Betz. I'm an emergency physician at the University of Colorado, where I'm a professor of emergency medicine. I do a lot of research related to firearm injury prevention, mostly in the space of suicide prevention.
Thank you, Dr. Betz. Dr. Hirsh.
Hi, everybody. My name is Mike Hirsh. I'm a pediatric surgeon at the University of Massachusetts School of Medicine in Worcester, Massachusetts, and I've been working in the gun violence field for 40 years. And I'm very privileged to be one of the faculty advisors to the SAFE chapter at our med school.
Thank you. Greg Jackson.
Yes, good evening. I'm Greg Jackson, the Executive Director for the Community Justice Action Fund. I'm a survivor of gun violence, but been working in the implementation and advocacy space of proactive strategies to address violence for 8 years now. So excited to be here and share a little bit more about our work.
Thank you. Dr. McKay?
Hi, I'm Sandy McKay. I'm a general pediatrician at UT in Houston and the director of advocacy for the Department of Pediatrics. I also specialize in education research, especially around firearm safety counseling, and also in the PI for our Injury Free Coalition for Kids site. I'm excited to be here as well.
Thanks. And Cassandra Paschall.
Thank you for having me. My name is Cassandra Paschall. I'm a research assistant with Pure Violence Global. I lead our city outreach efforts for implementation to cities, as well as manage our Portland initiative for political violence. And I'm excited to be here. Thank you.
Thank you again to all the panelists for being here tonight. We're very excited for your presentations, and we're going to begin with Dr. Betz's presentation.
All right, so our first speaker is Dr. Betz. So she's gonna share her own slides. So she is an emergency physician and professor of emergency medicine at the University of Colorado School of Medicine. She's also the director of the Firearm Injury Prevention Initiative at the Injury and Violence Prevention Center at the University of Colorado. And she's also the co-founder of the Colorado Firearm Safety Coalition. So Dr. Betz, I will hand it over to you.
Geez, are you seeing the correct slide view?
We're seeing the notes view right now.
Oh, geez. You'd think that you've done this enough that you would know how to do it. Okay, hang on. Are we good? Sorry about that.
We are all set. Yep, looks great. Thanks.
Well, thank you for having me. I think you can tell as an emergency physician, I like being really busy. So congratulations to all of you who are listening and med students planning your own career paths. There's so much that you can do to make a difference in your patients' lives at the bedside and in the community. So I lead the Firearm Injury Prevention Initiative at the Center for the Prevention of Injury and Violence here at CU. And we really work from this single kind of truth, which is that none of us wants these firearm related injuries or deaths in our homes or our communities. Whatever the cause, whether it's suicide or school shootings, we recognize none of us wants to be losing loved ones. And we need to address this through policy and education and research, but most particularly, in my opinion, collaboration. And that's what I'm going to talk the most about today. So I know I'm going first out of alphabetical order, but I will take that chance to also put firearm deaths in context a little bit and specifically talk about suicide, because I think too often suicide is left out of the conversation. I think probably most of you know there's about nearly 40,000 firearm related deaths per year in the United States. 60% of those are suicide. And here in Colorado, the number is 73%, followed by homicide, including domestic violence, legal intervention, and then the school shootings and the accidental and so forth are really tiny percentages. I didn't show mass shootings on here, but it's also maybe less than 1%. And I'm not trying to say any of those things are less important than suicide, but I think the deaths from suicide are deaths, and they have big implications for the people surrounding that person, and they're preventable. And so I'm a firm believer that we really need to be looking at the whole picture and recognizing it's going to take different solutions. So I want to leave you with a little bit of the rationale for why we can prevent firearm suicide. The first is that the final decision to attempt suicide often occurs within only minutes to hours in the context of a larger crisis. So if we keep someone safe through that time period, hopefully they can get treatment and get better. In fact, we know the vast majority of people, even with suicide attempts, do not later die by suicide. But if somebody attempts suicide with a gun, it is very unlikely they will make it to my ER, to the hospital, because the fatality rate is close to 90%. And so that's what we try to explain to people, is it's really about just keeping firearms inaccessible during times of risk. Very much like having a designated driver. It's not about taking away your friend's driver's license. It's not about calling the cops. It's not about telling him he can never drive again. It's about making sure he gets home safely when he's impaired. Ideally, absolutely, secure storage, reduced access would be a long-term goal. But again, even short-term changes during times of risk may have a big impact. So the question then for me as a clinician was like, how do we do this? Because we recognize that people own firearms for all different reasons. How do we work with them in ways that feel meaningful when it comes to things like storage and reducing access? In fact, what are the things that really drive storage behaviors? What determines how someone stores it? And we do have some research on that. So things like certainly people who have firearms for personal protection tend to store firearms differently than people who go hunting once a year and so forth. But really importantly, one of the things that is associated with storage is the belief in that link to suicide risk that I just told you about. So if people understand that access to a firearm during a high-risk period increases the risk of suicide death, they're more likely to lock up guns. And that, to me, is something we as clinicians can be impacting. But I think relatedly is the question, what are the messages, and maybe more importantly, the messengers that are going to be the most impactful? And newsflash, it's not always doctors. Like, it really depends on the situation. And I believe we absolutely have a role, but we also need to think about how we work with the community to use trusted messengers to get these sort of cultural changes to happen. This was one example of one study we did a long time ago, but I really liked it because it was about how we talk about this and what is it that gun owners want us to talk about when we are counseling on reducing access to firearms. And it's about identity. It's about recognizing the culture of responsibility and safety within the firearm owning community, using trusted messengers, talking about voluntary, temporary changes, putting it in context and so forth. And little changes, like instead of saying lethal means restriction, say lethal means safety, that we avoid words like restriction and confiscation, because that's not really what this is about. And we don't want patients to suddenly fear that we're calling the police or asking them to change something that might be deeply ingrained in their identity. And so it was about in 2015, and I should say I don't come from a firearms background myself. I grew up in Colorado, and I have friends and family who hunt and own guns for other reasons. But this is not something I thought was going to happen, and it has been the most fulfilling part of my career for sure. Back in 2015, based on an article I wrote, a physician, Michael Victorov, who's in the middle of the picture on the bottom left, reached out to me. He's a family physician and firearm instructor, and he said, all right, let's do something. And so we formed a coalition based on models in other states. And it's been just really rewarding to find ways to talk with firearm retailers and owners to find common ground on what we can be doing to prevent firearm deaths within the community. Oh, and specifically suicide deaths. I think one of my favorites, again, you never know where you're going to end up, is we did a couple ladies' night events at one of the gun clubs. These are chances for women to come together, and they get range time at a reduced price. There's no wine, it's not book club, but you know, these were women who were very knowledgeable about firearms, but many of them had never heard the most basic messages in suicide prevention, like that it's okay to ask someone if they're having thoughts of suicide, or what they could do to help look out for their husbands, for their kids, for their partners, for themselves. And it really just showed me, I think, an area that public health has missed out on, perhaps because we haven't quite know how to build those bridges. As I mentioned, there are variants of so-called gunshot projects around the country. And I should say in Colorado, we have a larger gunshot project actually run by our state, which is fantastic. And our coalition really tries to support them. But these are examples where public health professionals and come together to meet locally with individual gun shops and provide materials, posters and brochures that they can give out, the posters they can put up, other kinds of messaging. So again, it's coming from a trusted space, from a trusted messenger. There are lots of really cool examples. The National Shooting Sports Foundation and the American Foundation for Suicide Prevention have a national partnership, which is really just mind-blowing to me. It's really fantastic. And they have these materials, Have a Brave Conversation, and sort of using that, again, drawing on that identity piece of you protect your friends and family and you're a tough person. It's okay to talk about these things. On the bottom left, you can see an example from the Navy. So the Department of Defense and the VA are all over this, that we need to be talking about firearms. The Safer Home Suicide Aware is a program out of Washington State that has done a lot of work developing training for firearm retailers about how to identify suicide risk and when to intervene. And then Walk the Talk America is a favorite organization of mine that was founded by two self-proclaimed gun guys. One is also a therapist, and they're really interested in bridging mental health and the firearm world, both by instructing the psychology field about sort of what firearm ownership means and what people are afraid of in terms of confiscation, but also encouraging the firearm world to talk more about these things. I'm not going to talk a ton about our maps today. This was a fun project where we tried to look at sort of, with the help of a medical student, which places in Colorado would be willing to temporarily store firearms for people. And we're grateful to have then received NIH funding to do a bigger evaluation of this. This is an example, again, of something that was a sort of idea we had and has led to a lot of really interesting discussions around community resources and how we interface with the community. And I do want to leave you with just one last thought related to firearm suicide. I think very often in this space, perhaps because people come from a policy background, their first thought is they jump to extreme risk orders when they think about suicide risk. And I really just want to emphasize it's about doing the voluntary temporary things first. And so we developed an infographic to help explain to people kind of where extreme risk orders fit in, that they really should be the last straw. So with that, I'm going to stop. I'm happy to take questions. I'm also happy to have people reach out to me. I love working with students and residents, and I'm so glad that you're all here tonight and interested in the field. Thank you so much for having me.
All right, thank you so much, Dr. Betz. So if you guys have any questions, go ahead and put your questions in the Q&A box. There should be an option for it at the bottom of your screen, and we will do questions at the end with all of our panelists.
Courtney, there's one question in the chat. Do you want me to answer that now? Yeah,
go for it. Yeah.
Yeah, sure. Really good question. What kind of pushback have I received from conservative politicians or lobbyers? I think from the more conservative side or the gun owning side, sometimes there's skepticism of what our real intent is. And so we're very careful in being transparent and how we talk with people and so forth. I don't do advocacy work, you know, really pro or against any kind of legislation generally. I will say sometimes the more significant pushback I've gotten has been from the medical community, of people saying that what we're doing isn't ethical, or somehow that we should all be advocating for really just all guns being confiscated right away. And my take on that is that this is a harm reduction approach, and we need to meet our patients where they're at and help them be as safe as possible. And for some, that hopefully will mean maybe changing a decision about owning firearms. But so it's interesting. We've gotten pushback from both sides, but the pushback is tiny compared to the amazing support and interest that people have in this kind of work.
And then Dr. Betz, there is a question in the Q&A box. It says, what is your position on gun control legislation?
So that's a great question. And I will say, as I just mentioned, I don't do advocacy for or against gun control legislation. I try to look at each policy as a standalone, as opposed to blanket statements. And I think really importantly, when we're crafting legislation, we need to be thinking about how we're engaging groups in the discussion of it, including its implementation, because the Colorado kind of passage of the red flag law is one example where there was a chance to make the law more acceptable to both sides. And I think it's great we have one. They could have made tweaks, they chose not to, and it led to a ton of controversy and places saying they wouldn't use it and things. So, but that's a long-winded answer to say that I don't have a single position.
All right, thank you, Dr. Betz. We're going to keep track of all the questions as they come in, so go ahead and keep posting if you have them, and then we'll get to the rest of them at the end. Thank you so much, Dr. Betz. So we'll be moving on to our next speaker now, which is Dr. Hirsh.
So Dr. Hirsh serves as a surgeon in chief for UMass Memorial Children's Center and co-founded Goods for Guns in 2001. And today he's going to be speaking with us about the benefits of a gun buyback program. Dr. Hirsh, over to you. You see your screen.
Can you hear me now?
Yes, we can.
Okay, great. Thank you very much for inviting me. It's really Dennis's invitation or promotion that got me here, so I'm very honored to be part of the panel. I don't have anything to disclose, and I'm going to try to, in a 10-minute session, see if I can get us to understand a little bit more about what gun buybacks are about. But we have a big problem, as you all know. It's a iconic image like this from Sandy Hook, which will have its 7th anniversary this coming December 14th, that made everybody, I think, very much aware of how far things had gone with school shootings, assault weapons, et cetera. I think you've already heard from Dr. Betz, that's only a very small percentage of the gun fatality issue. That night on PBS, Mark Shields, who has unfortunately since retired, made this statement, which I thought was very moving, about the fact that more people had been killed in domestic gun violence, including suicide, than in all the wars we had ever fought. And in the 8 years since then, it's gotten no better, obviously. So we are a country that owns 42% of the world's weapons, even though we only represent about 4.5% of the world's population. And the estimate is that somewhere between 33 and 45% of households own firearms. In my state of Massachusetts, that number is much lower. It's only thought to be about 11 to 15%, but that number is going up. And also the number of guns in the individual homes is going up. So there are a lot of guns out there. 40 years ago, November 2nd, which is coming up obviously next month, my best friend, John Chase Wood II, was murdered right in front of the hospital where we both served as residents at Columbia Presbyterian Hospital. And that got me going on this journey. After the murder, it was highly publicized in New York City. Here was a coverage of the funeral, which was one of the saddest days I've ever been to. And the papers were just full of these stories about how could a doctor, in this case, John Wood had been a pediatrician before he decided to switch into surgery, and had also been a Juilliard-trained musician. How could this wonderful person be gunned down? And we didn't know who it was. And the neighborhood around Columbia Presbyterian, which has now been celebrated in the musical, after serving for another murder. So after that terrible murder, my chief of surgery, who's pictured here, Keith Reemsma, talking to Dan Rather, who at the time was the anchor for CBS News, pulled together a meeting of our residents. I was president of the House Staff Committee at the time, and we all got together and met in the Audubon Theater, which was across the street from Columbia. It's also the place where Malcolm X was assassinated. And we had as our guest speaker, Sarah Brady. And just 6 months before John's murder, Sarah's husband had taken a bullet for President Reagan. You may have read that his killer was just released by the courts this past week. And Sarah was the first founder of the Brady campaign to end handgun violence. She came to speak to us and really impressed. For the first time, I had never heard anybody speak about this process called lethal means reduction. She made an analogy that really stuck with me. Walter Reed, who was the famous military surgeon who figured out that the vector of yellow fever in the Spanish-American War, here's Teddy Roosevelt doing his rough riding, was the mosquito. He didn't know how to treat yellow fever. He didn't have any antimicrobials or antivirals, but he knew that if he could conquer the mosquito, he could conquer yellow fever. And he did by telling people to wear long shirts and long pants and get mosquito netting and get rid of standing water in the army camps around Cuba where the fights were being held. And in so doing, he reduced yellow fever by 95%. And that enabled the United States, 10 years after his death, to successfully complete the building of the Panama Canal after 3 unsuccessful trials before. So she said, look at the gun like the mosquito. We can't do anything at our level about necessarily about the terrible poverty, the racial hate, the violence, the anger that's out there. But if there's less circulating weapons, we will potentially reduce some of these hateful incidents into fist fights and other kind of non-lethal confrontations. So it just so happened that I rode to the funeral of my friend John Wood in a bus sitting next to Dr. Barbara Barlow. And you can see the hat that I'm wearing. She's the founder of the Injury Free Coalition for Kids, which is a national organization of 44 level 1 pediatric trauma centers dedicated to injury prevention. And they follow the ABCs that she has outlined, which has now been adopted by the American College of Surgeons. And every time a trauma center gets inspected, they have to show that they have active injury prevention following this algorithm. She didn't believe that there was a way to really deal with firearms in this way. But I kept it in my heart. And when I moved on to do fellowship and then became an attending at UMass, I kept thinking about ways that I could make a difference with firearms. In 1992, I moved to Pittsburgh with this gentleman, Dr. Matthew Mazziello, who's a professor of pediatrics and a pediatric intensivist. And we started a trauma unit at a hospital in Pittsburgh called Allegheny General that was in the middle of a massive gang war over the crack epidemic, which had moved from the East Coast towards the Midwest, and Pittsburgh was in the middle of it. And we were getting so many gunshot wounds in teenagers and preteens that we wanted to figure out a way we could work with the community to make a dent in that. And Dr. Mazziello, like I am from New York City, and we read about this gentleman, Fernando Mateo, who was a community activist at the time. He owned a carpet store in Washington Heights, and he was so upset by the number of gunshot wounds that he was experiencing and his young son was having to navigate around as he went to school in the Heights, that he opened up his carpet store on one particular morning and offered free carpet for anybody who brought in a gun. And 2,000 guns were collected that day. So we decided to try to set up a similar situation in Pittsburgh. And this is our first day of trying this in Pittsburgh. We were told we were only going to get 25 weapons. We got 700 on the first day and 700 on the second day. You see a lot of rifles. You know, Pittsburgh is the land of the deer hunter in Western Pennsylvania. But most of the weapons we got, over 2/3, were handguns. There were many sawed-off shotguns, and there were even some really lethal weapons. So I started the gun buyback with Dr. Mazziello in 1994 in Allegheny County, and since that time, we have done about 13,000 weapons have been retrieved by the Goods for Guns of Allegheny County. When I moved back to Worcester in 2000, I negotiated with the Department of Public Health, the police chief, and the district attorney to try to set things up in Worcester again as a new gun buyback program. So we did all these different injury prevention things. I won't bore you with all the normal kind of injury preventions that we did, but I will say that unless you address this kind of violence, this kind of mayhem amongst the urban population, and also, as Dr. Betz pointed out, in the suicide risk population, you're not going to have credibility, because this is the stuff that gets the headlines. If it bleeds, it leads, and that's how people feel about injury prevention. They're not as happy about you doing a playground as they are about you getting something done about gun violence. So we started the gun buyback in 2002, and we've collected all different kinds of weapons since then, and we've expanded to include large swaths of central Massachusetts, the Commonwealth of Massachusetts, Connecticut, and also a little bit in California. Interestingly, they have kind of watched our progress and tried to parallel our program there. So this is the totals just for Worcester. And the only thing I wanted to point out to you is that we've collected approximately 3,800 weapons in 19 years. This will be our 20th anniversary coming up this December. The last 7 years, we've coordinated our date close to the anniversary of the Sandy Hook massacre, because I think it resonates with people. And we've had some folks from Connecticut come up and help us publicize the event as a way of giving tribute to the tragedy that the parents went through down there. I also want to point out to you that the total cost of doing this for 19 years is less than the cost of having 6 gunshot wound victims come into our hospital. We're only paying in our community $50 a firearm. And so the way this works is that the district attorney grants total amnesty to anyone that brings in a weapon that day. The police check it and make sure that it's operable. If people want to bring in ammo and people want to bring in other weapons, that's fine, but we only reimburse for guns. And lately, we have been reimbursing for replica guns too, because they've been involved in several robberies and breaking and entering. We don't do forensics on these guns. They are considered dead, so we just crush them up for many years. More recently, though, we've figured out something else to do with them. So I just want to show you, this is from 2015. We have updated data that I didn't get a chance to put on a slide today, but Worcester has the lowest penetrating trauma rate of any of the largest cities in the Commonwealth of Massachusetts. I don't think it's causal from the gun buyback, but we have a very multi-pronged approach towards gun violence in Worcester. And most of the press and the interest, the public information that goes out about the day lead up to the gun buyback. Here's an item that was made out of guns from Pittsburgh that's sitting in front of the City Hall in Providence, Rhode Island. The artist who was working with these metal objects took the guns to work on when he moved to Providence, and then became too heavy and bulky to ship back to Pittsburgh. So it's our monument to the gun buyback, but it's sitting in Providence, Rhode Island. And this is just a close-up of how the guns weather there. So everybody started to agree, I think, when all these mass shootings were happening, and especially when the recognition that suicide was almost 2/3 of firearm violence, that it's very important for docs to be able to counsel their patients about the importance of gun safety. And what we've been trying to do at UMass is to try to have every encounter involve like a risk assessment. So maybe you have a gun in the home that's never been a problem, but if you have a demented old person in the home, if you have an inquisitive toddler, if you have a depressed teen, if you have an angry spouse who just got laid off from work, the risk suddenly goes much higher. If you identify this and say that you want to get rid of the gun, what do? Well, in the case of drugs, the DEA collects twice a year unwanted pharmaceuticals. And we get many, many tons of unused opioids, which otherwise might have fallen in the hands of the black market and made it into the mouths of some kids that would then make the conversion from oral opioids to heroin. We didn't have an equivalent model for that in the gun industry because we didn't really give easy access for people to bring in their guns, no questions asked. Many of these guns have been found in the house or they're illegal. People don't have the proper permitting to have it. It's great to be able to say, I just want it out of here. And we give a reimbursement, but it's a very nominal reimbursement of local stores that have gift certificates. We give them out as a token of our appreciation for people coming in. The gag of doctors that started in 2012 in Florida, it took 5 years to adjudicate. And that really had a chilling effect on doctors being willing to even take these topics on. One of the real heroes in this is my friend, Dr. Judy Schechter, who's now the president of the American Board of Pediatrics, who challenged this in the courts and got that law in Florida overturned. So now the gag should be off and we should be able to speak freely about this. And taking advantages in Massachusetts, this woman is Maura Healy, who is our Attorney General, and Dr. Bob Sagi, who is a very well-known author of the AAP Connected Kids protocol, worked with me to come up with this pamphlet called Patient Conversations of Firearms, which teaches doctors and medical students how they can bring this topic up without pushing red flags for people. So you know from Dennis's presence that we have a very active SAFE chapter, and this chapter has gone above and beyond. They formed an optional enrichment elective, which is why Dennis was late today to this. She was running that. And they've gone to gun owners and actually did live fire with them to understand better what firearms are about and what gun owners think about firearms. I've done a lot of advocacy on this, and it really helps to have students join you when you're doing this advocacy, because your bright faces and your bright ideas about the future have a lot more weight than when the old white guy comes out and talks about this stuff. So we're hoping to go bigger and better. And the biggest development this year is that following 2019, where we did this a little bit, we took the guns that we accrued in the last 3 gun buybacks, and now we have made them into garden tools with the help of blacksmiths like John Hayden and this organization from New Haven called Swords into Plowshares. We've used it to garden on a community garden that the medical students at UMass do, where all the produce that's produced will get given to the local food banks and to homeless shelters. And we're doing this, as I mentioned, in New Haven, in Hartford, Springfield, Massachusetts, and San Mateo, California. So I'm going to quit here and just say that I also do a local cable access TV show for the Worcester District Medical Society, which is an arm of the AMA. And I had a patient, Lanaya Johnson, who was, as a 13-year-old, inadvertently shot sitting on the porch of his aunt's house, leaving him, unfortunately, to be a T9 paraplegic. He's done remarkably well. He's a radio and record producer now in Providence. I asked him to help us with promoting the gun buyback about 5 years ago. He appeared with his mom, and he did a beautiful job explaining what it was like with his rehab and how that single bullet did such a whirlwind of damage and change in his life. When I was just about done, and I know I'm just about done now, I was asking my guests, do you have any last comments before we say goodnight? And he said, I wish you could have just collected one more gun. So that's what keeps me going, along with the wonderful med students that I've worked with. And I'm so grateful that they got me here, and I'm very proud of the work that SAFE is doing. And I hope we can all make a difference to try to reduce this scourge of violence. So thank you very much.
Thank you so much, Dr. Hirsh, for that fantastic and powerful conversation. We have seen a couple of questions come through. We're going to wait to hold those for our large Q&A discussion at the end to make sure we have enough time for each of the panelists' presentation. And so Courtney is going to introduce our next speaker.
All right. Sorry, guys, about my video. It won't turn on for some reason. But our next speaker is Greg Jackson. There we go. So Greg Jackson is the executive director of the Community Justice Action Fund. He is a survivor of gun violence himself. He has served as the director of the DC Mayor's Office of Community Relations and Services. He's also led community engagement and communications for the Washington, DC's Office of Neighborhood Safety and Engagement. He's held many roles as a community organizer, including running the largest midterm election voter registration program in US history. So today he's going to be introducing the topic of importance of investing in community violence intervention strategies and the federal advocacy work that the Community Justice Action Fund has been doing. So Greg, we will hand it over to you.
Awesome, thank you. I guess before I pull up the slides, I just wanted to share, I come to this work not by choice. I've been someone who's been passionate about politics my entire life, and policy and the power of making change and bringing about change through policy, but never envisioned that I would be in this fight. And growing up, I lost a childhood friend to gun violence. I had nearly been shot 4 times. And then on April 21st, 2013, I was shot as a bystander. And I'll never forget a few things. One was, when I arrived at the hospital, I was met by not my nurse, not my doctor, but investigators who interrogated me about my whereabouts and what I was doing and why was I in the streets when I was actually leaving a wedding party. When I was shot. And when I met my surgeon, he shared I'd only had about 26 minutes to live based on the blood loss. And that really not only traumatized me, but helped me really internalize how we see violence in Black and brown communities. It's always seen as a criminal issue, as a law and order problem, and not necessarily looking at how can we heal and save lives and help address this crisis as the public health crisis that it is. And so that's what inspired me to really start and get into this work. I quickly found out from doing this work that what Black men in America go through, what might be normal to us is rare to the rest of the country. And that this crisis that's literally wiping us out as the #1 cause of death for Black men and Black youth is seen as an anomaly or a once in a lifetime disaster. And I think the way mass shootings have played out in the media and the political response to mass shootings has been very prevalent and kind of affirms that we look at violence different based on different communities. And hopefully I can share a little bit about our solutions and our work, but just wanted to provide that context to why I'm in this space. So let me share my screen real quick. I'm definitely going to be fast on these slides. So hopefully y'all can see it okay. I don't know, maybe. All right, cool. So our organization was founded in the wake of the shooting in Charleston, South Carolina, when we saw how the death of Black bodies was treated so much differently than when it was suburban or white youth or white adults in this country. And our organization was created to really, 1, change the narrative around how we see gun violence, 2, to build political power to address this crisis specifically in Black and brown communities. And then lastly, to advance bold policy to help address this crisis that's tailored specifically to our trials and what's happening in our communities. I think we've already kind of talked through the stats and the urgency through some of my other presenters, but a couple of things to highlight is that, when you look at homicides specifically, over 74% of those lost are Black or brown. And that's a number that's increasing both in numbers and in percentage of of who is actually dying at the hands of homicide. We've also seen major spikes in homicides across the country during the COVID-19 pandemic. And alongside that, we've seen spikes in police violence and police brutality, as well as an increase in the economic impact. And one thing that we remind folks is that there is a real dollar cost. I think the previous panelist spoke to this, but for every homicide, there's a cost between $500,000 and $2 million per homicide, negative impact on our economy. And when you add that up, that means $280 billion are lost in our economy every year just to the crisis of gun violence. The way that we look at gun violence, when I was shot, I wasn't shot by someone who bought a big fancy rifle out of a gun store. When my mentee who was shot, Karan Brown, a few years ago, that gun was illegal, and was pushed there illegally. And we actually found the murder weapon being sold on social media by a 10-year-old, actually. And what that kind of reminded me, and I think is a reality, unfortunately, is that our neighborhoods are saturated with firearms. And so if we only think about getting firearms out of the community or preventing future gun sales, we're pretty much giving up on an entire generation that's dying from guns. And when you look at the lifespan of a firearm, it can be anywhere from 15 to 30 years. And so we can't give up on communities that are suffering from violence now. And while buybacks are good and different strategic ways to pull guns out are helpful, ultimately we have to think about how do we serve and reduce violence by focusing on the people, acknowledging that the firearms unfortunately are already there. And so the way that we look at it is really there's kind of three major layers to how we do that. One, we intervene and triage the violence that's happening right now. And we can do that through community and hospital-based violence intervention program. Excuse me. We can do that through survivor and victim services. And we can also do that through healing and trauma services. And so that's what's most urgent. And unfortunately, in most communities, especially at the city level, we don't have those types of resources or programs staffed up or well-funded. Secondly, we need to think about how do we reduce the risk factors that lead to someone acting out violently. And unfortunately, that is something that's a little bit unpredictable. There's a study done by the Violence Policy Center on Black homicide every year. And one fascinating stat was that 68% of homicides in the Black community are not connected to another felony. And so if we're only thinking about this from a crime approach, we're essentially missing 2/3 of the problem. And so our organization is a strong advocate for proactive cognitive behavioral therapy programs like Advanced Peace that work with those who maybe have had a violent history or have shown some violent outbursts that may not be firearm or gun violence, but could lead to that, but can work with them to shift their lifestyle and shift their way of thinking and their behavior. Strategic workforce and development programs that target those who are most desperate or most in need. And then again, looking at firearm access and some of the malicious marketing and targeting that focuses on Black communities, Black and brown communities. And then lastly, we are also advocating for addressing the root causes that lead to some of the desperation and lead to fueling those risk factors, whether that's housing and environmental issues, physical, emotional, mental wellness, and economic and social inequities. And so we really feel that America has unfortunately, and I blame the NRA, but America has polarized how we address this crisis into just gun control or right to bear arms. And we've overlooked the complexity of this crisis and all the other strategies and tactics that exist that can reduce violence, especially homicide in our communities that we're suffering from. So I'm going to kind of slip over a few of these because I know I'm a little long-winded. But I wanted to just quickly share, the work that we've been doing over the last couple of years. We actually worked to organize the first hearing in American history on urban gun violence in 2019. That's our founder, Amber Goodwin, there to the top left. It's pretty disturbing that Congress never talked about it until 2019, but we helped organize that and it really elevated the issue. That was also the year that the Break the Cycle of Violence Act was introduced, which was the first major congressional piece of legislation that would fund violence prevention programs and at-risk individual programs in Black and brown and urban communities in history. In the summer of 2020, unfortunately, we saw what happened with police violence and the spike in it, but also the heightened awareness. And so we launched a campaign to acknowledge that police violence is a form of gun violence. And if we don't acknowledge that the American way of meeting violence with violence is failing, then we'll never see this as a comprehensive a problem and start to introduce comprehensive strategies. We also introduced the Peace is Essential campaign, where we pushed on legislators and elected officials to acknowledge that peace-bringing organizations and efforts are essential, just like first responders, just like law enforcement, just like healthcare workers, and deserve to be funded and supported through the pandemic. Since then, we had a pretty good response to it, but we were actually connected directly with the White House. We submitted multiple transition recommendations. We created a coalition of over 220 organizations, whether it's NAACP or Color of Change, down to local groups like Safe Street Baltimore, to work together to put pressure on the White House and on Congress, but also to present new and innovative ways to address violence. For the first time in history, the White House held their first meeting on community violence intervention strategies February 17th. And on April 8th, I was lucky enough to be there when the president rolled out his first round of executive actions, which included changing 26 existing grants to include funding for some of these violence intervention programs and strategies. Since then, we helped organize the first ever White House visit to a community violence intervention site where they met with survivors, they met with previous offenders that have been rehabilitated, and learned firsthand the healing and the impact of these programs. We also launched a National Fund Peace Tour that traveled the country to really elevate these solutions and their importance. And this summer, the Break the Violence Act was reintroduced with $5 billion in the bill, which is now heading over to the House floor. Additionally, Biden was able to get $5 billion for these types of strategies included in his Build Back Better Act that's being heavily debated in Congress right now. So I'm going to jump a little fast because I think I summarized that. But just a couple key things that are still happening right now. We also were able to make a pretty major adjustment to Medicaid to make sure that it can cover gun violence services for survivors and also programs that support survivors. We were able to get the Victims of Crime Act adjusted to ensure that those who maybe are a victim of violent crime but are not actually complying or working with law enforcement are still eligible to receive resources to support their healing and their recovery from violence. And then we also work with the White House to create a collaborative, which organized 16 large philanthropies across the country to work together to create non-federal or non-government funding sources to support these programs that intervene and support those impacted by violence. Last thing I'll share before I jump back, I could definitely talk about this all day. We also, through our Fund Peace campaign, have been doing a ton of local advocacy over the last couple of years, and we've seen a tremendous amount of progress. Previously, nationwide, you would see maybe $40–50 million for these types of programs. Now we're looking at billions, and I mean that literally. States like Illinois has invested $150 million, New Jersey $45 million, even Tennessee has committed to $10 million this year to invest in these strategies. Cities across the country have started to step up and invest in this for the first time. Akron, Ohio, for example, $24 million. St. Louis, Missouri, $1.5 million. East St. Louis, Illinois also did $1.5 million. And even places like Baton Rouge invested $2.5 million. And so we're starting to see that these strategies and efforts, not only do they work, but we're starting to see some real momentum at the city and state level to invest in these strategies and really look at addressing violence by focusing on the people and not just the firearms and not just the crimes that are so tied to the stereotypes of why violence is happening in our communities. So that's all. You can learn more here, and I'm definitely open to questions, and I'll be here for a while, but thank you so much.
All right, thank you so much, Greg. If you have questions for Greg or any other panelists, keep putting them in the Q&A box. And for time, we'll do all questions for our panelists at the end, and we will keep going.
So our next speaker will be Dr. McKay. And Dr. McKay is a pediatrician and a professor of pediatrics at the University of Texas Health Science Center at Houston. She served as the co-director of the Social Justice and Advocacy Educational Rotation at McGovern. And she's developed a firearm safety counseling workshop for physician trainees. Dr. McKay, over to you.
Thank you so much, and thanks for the promotion. I'm an associate professor, so I'll be getting there pretty soon. Today, I'd like to talk a little bit about firearm injury prevention in children specifically. I don't have any disclosures. As so many of my colleagues have alluded to before, firearm injury prevention in children is the second leading cause of death in children, only following MVAs. And when we look at motor vehicle accidents, what we can see here on this chart, which is one of my favorite to share, is that we see a nice steady decline over the last few decades in motor vehicle crash deaths in children. And a lot of this can be attributed to things that we see in education, research, and policy and advocacy. And really, it just is a reflection of, a combination of those efforts really do make a difference in children and reducing death and injury. Immediately below it, what you see is firearm-related injury, and really we haven't moved the needle very much there. So that is an opportunity for us to make some improvement. Over on this side just kind of shows a breakdown of different age ranges, and what you can really appreciate here is unintentional injury is much more common in the younger age group, and as you get older, you start seeing more emergence of suicide in the more adolescent population. For children specifically, it's important for us to remember that over 3,000 children yearly die from firearms. A lot of children in this world, 4.6 million children 18 or under, are living in a home with a loaded and unlocked firearm. So this is your kid that is in a home where there's a firearm that is stored like hidden in a dresser drawer, or classically like hidden on top of a closet, where parents are thinking that their child maybe isn't able to access it, or that they've secured it by hiding it from someone. More than a third of adolescents say that they can access a loaded firearm within 5 minutes. And even reflecting back to Dr. Betz's talk, it's that suicidality, within minutes is when they're thinking about that action. And if they can access a firearm within minutes, that's a concern. And really the single most modifiable risk factor for firearm injury in children is that access. Children know where they have those firearms, especially in those parents where they say, oh, my kid doesn't know where we keep those firearms. They know where they are. The majority of those unintentional shootings do occur in the home. Over a third of children will also admit to handling the household firearm. And having that access in the home does increase your risk for homicide and suicide. In the healthcare profession, for us as pediatricians, we spend a lot of our time doing anticipatory guidance. So as part of our well child visits, we talk about when to introduce solid foods. We talk about a lot of safety things like, when you can turn your child around to do forward facing in the car seat. And we also talk about safe storage. And so looking with parents, the majority of parents by far do think that the pediatrician should be advising about safe storage of firearms. And they think that the pediatrician should ask about firearms in the home. And only a small percentage of firearm owners would be even offended if we were to recommend that a firearm should be removed from the home for safety reasons. And this is classically the teenager who is depressed or suicidal. But the problem is we're not really doing a great job about talking about it within the clinical encounter. And why is that? It's because we don't teach it. We do a very inconsistent job at teaching about how to talk about firearms in the clinical encounter. And that's because there's just a lack of a consistent or even comprehensive approach of education, either at the undergraduate or graduate medical education level. So in 2018, that was the year after the Las Vegas shooting. It was just shortly after the Parkland shooting. There was a survey of the medical schools across the United States. There were only 2 medical schools at that time that were offering any kind of education on gun violence. And McGovern was one of those. So we're really excited. At that time, we had just piloted a gun violence in the role of the physician's elective for our medical school. And so really it's just kind of telling right there that, where can we do some improvement for our education? Only a third of current pediatric residency training programs offer any kind of formal firearm safety counseling education for trainees, even though almost 2/3 of our pediatric residency program directors think that it's an important thing for us to be teaching about and counseling to our parents about. So really the gap here is telling. We have an opportunity to educate, but if we don't empower our trainees with the skills on how to do it effectively, it's really going to be difficult for us to be able to have that well thought, effective communication on a topic that can be pretty sensitive for some of our trainees. Only 50% of pediatric residents even routinely counsel. The most common barrier cited is lack of training. If you don't know what you're doing, you're not going to do it. It's pretty common knowledge there. Also, the concern is, lack of time. Our well child visits are 15 minutes, and it just seems like every time we're in there, there's a lot of things that we need to counsel and screen for. But certainly when we're looking at our demographics and our epidemiology, with firearm injury becoming so prevalent, it's one of those things that we do need to be addressing within our well visits. Another concern that's been brought up is we don't want to offend or upset our patients, which can also be reflective on just our lack of training and knowledge on how to be able to talk to our families as well. It's incredibly rare for pediatricians to offer any kind of safety device within the clinical encounter. So with UT, what we did was we developed a workshop where we did presentations. We partnered with our campus police to do a presentation on firearm safety. And we later adapted that to a video presentation where I demonstrated with my personal firearm on how to do some firearm safety protocols, as well as demonstrated how a cable lock works and how quick access safes work. In addition to that, we reviewed some epidemiology along with how to perform firearm safety counseling, and then looped into that some role-playing exercises for our trainees, where they were able to go through a variety of different scenarios, and they could practice with each other on how they would go about navigating that scenario so they can improve their own comfort level. When we surveyed the residents after they went through the workshop, what we found was by far the majority were not firearm owners. We actually had several comments in our surveys that said that they didn't grow up with guns. They felt very uncomfortable even talking about them, which is why they didn't really feel comfortable to screen. We found the majority weren't really engaged or feeling comfortable with that. And then on this slide, what we found was we did 4 data point collections after doing our initial workshop. We did pre, immediately post, and then we did a 3 and a 6 month follow-up, which is really exciting for us to be able to do 6 month follow-up on pediatric trainees. And what we found when we looked at just like their comfort level overall between asking about firearms, initiating a conversation about firearms, seeing it as an effective intervention or even a good use of time. Across the board, we saw improvement from baseline as seeing that as improving their skills. So we were pretty excited about, they're feeling more comfortable about what they were doing. At the 6 month follow-up, the residents were 5 times more likely to ask or counsel about firearm safety. And what we saw also was that for residents, they saw that perceived barrier of time decreasing over time, as well as those reporting that they didn't see any barriers. Reporting any barriers to firearm safety counseling was increasing between that pre and that 3 month follow-up. So the moral of the story here with what we found in our workshop was education works. If you can train someone, they can learn and they can get better at a skill, and that's awesome. Due to COVID, we've been given the gift of being able to experiment with multiple different platforms on how we can continue to provide education to our trainees, both with asynchronous by going through different modules and then working through different virtual platforms and looking at how our efficacy continues to go. And we're also expanding to other specialties like working with internal medicine and psychiatry and family practice as well. But at the end of the day, why does safe storage matter? Because when we can have households that have their firearms and their ammunitions both locked, what we find is that decreased self-inflicted firearm injuries, decreased unintentional injuries. At the end of the day, asking saves lives. What we also did within our clinics is we did another brief survey looking at our gun owners and asked them about whether or not they felt that money or finances were a factor in storing their firearms safely. And the majority by far said no, they did not think money was a factor. But then when we asked them if we were to give you a free or discounted locker safe, the majority, 58% said they would be extremely likely to store their gun locked if we gave them something free. Additionally, 40% reported that they did not know what to do if they had to remove that firearm from their home for safety purposes. So what we had decided to do was reached out to Dr. Betz's team because she's just awesome and amazing, to look at where are the opportunities for temporary emergency storage in the greater Houston area. Houston being the 4th largest city in America, we thought this would be a great opportunity to look at what is the culture here. The culture down in Texas as far as surrounding firearms is definitely very different than some other areas in the country. we found that there were 2 ranges and 6 stores that offered temporary storage in the Houston area. While we had them on the phone, we just kind of kept talking to them. This was done during COVID last summer, so we were able to just do some phone surveys with many of these places. When we were talking with them, we asked them what was the most popular purchase safety device that they were selling. What we found between shops and ranges, most of them reported that by far locks and safes were the most popular purchase safety device. And you can see here, stores are in blue, ranges are in red, locks, then safes, by far most popular purchase device outside of what comes with the firearm when you purchase it. And then after that were cases and vaults. And then we also asked them, if they did any additional safety information that was provided at point of sale. And 85% of the shops and 90% of the ranges said that they did provide additional safety information outside of what is included with, that's federally required, that's included with the firearm. So most of them said that they did add additional handouts. And when we see here on this graph, you can see stores or the shops are in orange and ranges are in blue down here. There was just a lot of wide variability. Some of them said that they did a lot of verbal counseling where they would ask, the customer, what they were buying their firearm for. Did they have kids at home? They would guide them through different scenarios of what to do in different situations. The ranges were more likely to refer them to classes to take if they felt that they were a new firearm owner. Some of the places would have signs that were posted to share information, and some of the ranges would utilize videos to have displayed while they were waiting for background checks to continue to clear. So just a wide variability, not only in the mechanism of delivery, but also like kind of the message that was being delivered at the time. And finally, for those that still continue to hang on the phone with us, we asked them if they provided any kind of suicide information at point of sale. And one range in 15 shops did say that they provided a handout. So what that told us was that that's another opportunity for engagement within our communities. One, to continue to kind of unify our messaging, because our messaging is always storing locked, unloaded with ammunition separate from the firearm. So that gives us an opportunity to say, hey, maybe we can make this message a little bit more consistent across multiple areas. In healthcare, certainly, we can get them when they come in for their well child check, but once they turn 3, I see them once a year. So there's only one time that I can really talk to them about a bunch of topics. And in a well child visit, there's a lot of points that I'm trying to hit all at one time. This could be a great opportunity to partner with the community to take that message and really take that out across multiple access points to really amplify and really share that message across. Also with the opportunity for possibly increasing where we can distribute safety devices to make them more accessible to families, to see if we can just kind of improve things and make things a little bit better, because at the end of the day, it's about making things better and safer for kids, because that's really what it's all about. Thank you.
Thank you so much, Dr. McKay. Really appreciate your talk. And for anyone with questions for Dr. McKay, please add them to the Q&A box. We will continue to monitor those and answer all of them at the end. And Courtney will introduce our final speaker.
All right, so our next speaker represents Cure Violence Global, Cassandra Paschall. So Cure Violence works with communities to stop the spread of gun violence by using strategies associated with disease control, detecting and interrupting conflicts, identifying and treating the highest risk individuals. Cassandra will be sharing specifics about Cure Violence's approach, as well as a few success stories. So Cassandra, we will hand it over to you.
Thank you so much, Courtney, for the introduction. And I want to thank all of the other panelists for sharing such informative presentations. I will try to go quickly, as I know we want to get to Q&A. For the purposes of this presentation, I thought I would go through Cure Violence Global's approach, components, and a few of our evaluations. So the Cure Violence Global approach is based on an epidemic control model. The organization was founded by Dr. Gary Slutkin, the former head of the WHO over 20 years ago. And what he saw was that the clustering of homicides in his hometown of Chicago represented clustering of the cholera outbreak in West Africa, which is when he decided to adapt this model to treating violence. So in these steps, when we talk about detection and interruption, That means detecting those areas within those cities or within those neighborhoods that have the highest rates of violence, and using communities, members that are credible messengers to interrupt that spread. The second part is identifying and treating the highest risk individuals. That means working with those individuals most susceptible for committing acts of violence in order to alter their behaviors, as well as connect them with appropriate community services. And then finally is changing community norms. So even those that aren't committing acts of violence, if you live in a community with high rates of violence, you see that as a normal behavior. So you want to get out in front of that. So that can look anything like a public education material being handed out, or it's a march, a vigil, it's an event to stand out and say violence is unaccepted, it is not normal here. So in terms of where Cure Violence is, we are in over 20 cities and 50 communities. We're also working internationally. So we're in Latin America, including in Honduras, Mexico, and Colombia. And we started in Chicago, but now I would say our biggest supporters are probably in New York City, where we have over 20 Cure Violence Global partner sites. In terms of what Cure Violence Global actually does, so when we work with a city, usually it might be with a health department, it might be with the mayor's office, or it could be a community organization reaching out to us saying that we have an issue and we want to resolve this. We want to prevent the violence. So we'll do an assessment. And what we're doing is first we're looking at the data. We're looking at what are those neighborhoods, where are those highest rates of violence happening? Then we're also going into that community and we're looking at what are the community organizations that are already existing there, that are already working with the population that is susceptible to violence. And through working with them, we can use their network to then identify who might be those potential workers that would then become what you might see as violence interrupters or outreach workers. And through that, we then do a hiring process. So again, safety first always when preventing violence, and workers need two things. They need access and they need credibility. Credibility is so important. So on this process, it's a questionnaire and it's also going out into the community and seeing are community members actually credible with those that are likely to be committing acts of violence in the community? Are they known? And once we've identified and compiled this together, then we actually develop the infrastructure for implementing the model completely. And that's through mayor's office, health department, or internationally with UNICEF. Then we do a training process. So our training process is first in the epidemic control management with the implementing partner. So they have an understanding of how they can actually monitor and evaluate the program to make it as effective as possible to save lives. We then do a training for the violence interrupters and outreach workers, first in the public health approach, so they have the understanding of the contagious nature of violence. We also teach them mediation techniques and strategies for how do we calm people down, how do we cool off individuals so that they don't commit those acts of violence. And then we also do data and support training. So we have a database so that our workers can actually input when there's an incident, they can input when it happened, what was the incident, and also can say whether it was resolved, what it was mediated, and what are the next steps. We also offer hospital training for hospital response, which I'll go into in a minute. And this last part of what Cure Violence does is we do ongoing technical assistance. So we're constantly adapting and changing based on the data and based on what the feedback is from the workers. And so that might be looking like booster trainings, or it might be looking at we need to go into new neighborhoods. So Cure Violence Global's hospital response, in an ideal world, it would be in every one of our sites, but unfortunately, usually due to funding reasons, it's not in many, but we do have hospital responses in New York City, in Jacksonville, and St. Louis. So what that means is that we work with the hospital so that if there is a gunshot wound coming into the hospital, they will call in our credible messengers. So the first 30 minutes after someone has been treated, it is crucial to have that credible messenger there to cool them off, to ensure that there are no retaliations against the perpetrator. And the credible messengers are trained in crisis intervention, de-escalation, and trauma-informed care. We also have our community staff that's actually out in the community, and they're working with the friends and families of the victim of the gunshot to ensure that they are not thinking about seeking revenge, they are not seeking about retaliation. And then for coordinating long-term recovery care, we do have a case manager that's working with the victim over time to ensure that they can transition back into the community. So sort of understanding our program and how the approach works, I wanted to also share our evaluations and what we've actually been able to get from employing this approach. The first independent evaluation was conducted by Northwestern University back in 2009 with our ceasefire Chicago site. And what they found was that there was a 41 to 70% reduction in shootings. In our most recent one done in Cali, Colombia, we also found a 30 to 47 reduction in killings. To say that we've been able to get positive results wherever we've been employed. And it's not just in reductions in killings and homicides, although that is always what we're focused on, saving lives, but it is really about changing those norms and behaviors, and also really trying to work to connect community members to address some of these needs-based grievances. So what we've also found is in our Chicago ceasefire evaluation that we were able to assist 45% of our participants in completing their GED or completing school. We were also able to help 87% of those that participate in our programs in getting job interviews. So it's not just about trying to change their norms and acceptability about violence, but also connecting them to get the resources that they need in the community. And then to make it a little bit more personal about how this actually kind of works out with a site, I wanted to end with a few examples. So first is our site in Cure Violence Atlanta. The site opened in 2019, so it's still fairly new. Last summer in 2020, Rayshad Brooks was shot by a police officer. There was a lot of tension in the community and people wanted revenge. And our workers were able to use their credibility, to use their techniques and what they've learned from the trainings to cool people off and prevent retaliatory actions. So that's just an example of how our community workers are able to go out and stop things before it turns to violence. The second is in St. Louis. The site opened in 2018. I spoke with the program manager there, Darren Seals, a few months ago, where he shared some stories for me about some of the success they've been able to have with the community. One was, unfortunately, he had told me there was a family whose father and son had been killed by gun violence. And there was a 14-year-old family member who wanted to seek revenge. So what they did is they went to the house every day. They checked in on the 14-year-old. They worked with him, tried to change his attitudes towards the acceptability of the use of violence to address his grievance, worked with him to work through some of the trauma and some of the grief he was feeling. And today he has not done any violent acts. So that is to say that our program is community-based. It relies on community partnerships and credible messengers, and it is effective at not only reducing homicide, but changing behaviors and norms and really making community well-being better. So I kept it really brief, so I'm just going to end it there so that way things can get jumped into Q&A.
All right, thank you so much, everybody. We do have some questions. So I will start off with a question for Dr. Hirsh. So this question is, how do you address the objection raised by some that the money given will be used toward purchasing new guns, even if indirectly, for example, a gift card to a grocery store frees up money towards a gun?
Honestly, we've been very careful making sure that any of the gift certificates that we give out would not allow for direct purchases of a gun. But I don't think that the amount that we're giving $25 for a rifle, $50 for a pistol, and $75 for a semi-automatic are going to get anywhere with purchases of new weapons. So that's, I think, why we've tried to keep the number low. And when we've done our surveys on the patrons, they've almost always said, about 85% have said, I'm not here for the gift certificate. I just want to get rid of the gun.
All right, thank you so much. So our next question for Dr. McKay, can you give a quick example for how to start a conversation about firearm safety counseling?
Yeah, so typically what I would do is I would frame it in the realm of context of safety. I use the sandwich method where you talk about something that's rather like less intimidating, like, is your child, where does your child sleep in their bed? If they're sleeping in their own bed, okay, how do you store your firearms at home? Being in Texas, I tend to use presumptive language and saying, how do you store your firearms, rather than asking, are there firearms in the home? And just say, how do you store them? And then after I have my conversation, I'll follow up with, and how does your child sit in the car? And so sandwiching it and keeping the focus on safety tends to kind of diffuse a lot of the concerns. And then when I get a question about like, well, why do you want to know? Just like, we're talking about keeping your kids safe, sleeping safely, riding a car safely. And again, with firearms, we want to make sure that, we're being safe with how you store them so that we can make sure your child doesn't have access to them, because kids are curious, teenagers are impulsive, so gun safety does matter.
Thank you, Dr. McKay. And the next question we have is for Greg. How can medical students get involved in advocacy work, and how can we be most effective in this space?
Yeah, I would say, look, the medical community has a very strong influence. And whenever white coats show up and demand policy change, it has a huge impact. And so honestly, we don't see enough. I think the one world that has not been loud or vocal enough has been kind of the healthcare world. Right now, there's a heavy law enforcement voice, there's a heavy community voice. But if we really see this as a public health crisis, we need the healthcare community to join us in this fight and be more vocal. As far as how, right now, a very urgent thing is every city, county, and state are deciding what they're going to do with their American Rescue Plan funds. And the White House has already said they want those funds to invest in community-led violence intervention and prevention strategies. So you can go to a hearing, you can call your city council member, your mayor, your county commissioner, and say, hey, how much money are you investing in these solutions? You were already instructed to do so. What's up? And so that's a very simple thing you can do at the very, very local level. To join us in our federal fight, if you go to our website, we have an action center where you can call your member of Congress, you can tweet, we can send emails with our language. So there's a lot of online activity you can do. And I also would just recommend too, there's so many local groups that are doing amazing work, like Cure Violence, organizations across the country, and just partnering with them, because ultimately, if you're not invested or a part of the solution proactively, they're going to wind up in your hospitals and you're going to feel that pain and trauma firsthand. And so why not get ahead of it? Just like any other public health crisis, I think healthcare professionals are always invested in the preventative measures. And I think these programs are actually a major measure when we look at gun violence.
All right, thank you so much, Greg. And then question for Cassandra. Has Cure Violence done any work with hospitals and clinicians? Do you think there are opportunities for partnering?
I think there are definitely opportunities for partnerships, especially Dr. Gary Slutkin always welcomes the opportunity to work with doctors and clinicians and has in the past. And I'm also happy to connect people to him for more specific questions related to sort of the epidemiology work as well.
Can I jump in real quick too? There's also hospital-based violence intervention organizations across the country. And so there's an organization called the Health Alliance for Violence Intervention, who really coordinates and engages all of those groups. And so you probably already have some form of this work happening in your hospital. And if you don't, you should advocate for it. And so, you don't necessarily even need to leave the hospital to do violence intervention and provide trauma services. So I would just recommend it. The Hobby, I'll put their website here too. But that they're kind of the authority on a lot of the hospital-based work.
Can I add on to that? I just want to say my experience is that the group of professionals working in violence and violence prevention is an amazingly supportive group. So I just encourage medical students, don't be shy, just email us, like find faculty members or contact groups, people who are working in the field. Like I'm always thrilled when I get notes from medical students, even at different schools. We will help connect you to options that are out there. So I think I want to amplify what Greg said about fair or not, we have a power of a white coat that we need to be using more to support great community organizations and other interventions. So don't be shy.
All right, thank you so much, Cassandra and Greg. And then Dr. Betz, last question for you. This question says, I am doing a research proposal on how successful gunshot projects are at reducing suicide in the community that they are in. Is there any data on the successfulness of these projects at reducing firearm suicide mortality?
So great question. As of right now, there's not, but thanks to all the efforts of groups like SAFE to get federal funding, there's actually a CDC funded project right now looking at that. If you want to email me, you can feel free to reach out to me and I can connect you with that team if you want to hear about what they're finding. Nothing is published yet though.
All right, thank you so much to all of our presenters for sharing their insights with us today and the impactful work that they are doing in each of their respective fields. And thank you to all of our attendees for taking time out of your busy lives to join us for Stand Safe 2021. So on the screen right now, there is a QR code. It is for the SAFE PayPal donation page. If you'd like to support the organization, all of the donations are tax deductible.
We have our social media handles up on the screen as well. As we mentioned before, there are chapters, we have 50 chapters across the entire US. And we, as we've heard tonight, we are stronger if we band together as united voices. We continue to learn and fight for this cause. So please follow us on Instagram, follow us on Twitter, stay up to date with the latest and greatest of SAFE across the nation. And everyone who registered for this event will be receiving a recording of the event. And we hope that everyone has a great week. And thanks again to all of our panelists.